Okay, so we'll get started. Well, we have a great crowd today. We've been so pleased with the turnout for these health research seminars. We tried as an organizing committee to make sure that we had representation of faculty across the health disciplines, and I think so far that seems to be paying off because each time we sort of have a core group of people that are here, but every time we seem to also see some new faces. So hopefully it's meeting the purpose, which is bringing together people involved in health research across UNBC and Northern Health and other partners that we have across the region. So I'll just start by welcoming all of you here in the room, but also I think we have some people also online. I hope you can hear me, and thank you for joining us. I just want to start. Could you just go down, please? I just want to start by just reminding people or thanking the people who have been involved in coordinating these seminar series. So this is, we have a lot of support from a variety of schools and departments across the university, and we've also been very fortunate to have financial funding from Sun Life. And this is the Health Research Institute initiative, again, to try to bring together health researchers across in the region and construction across the region. So I also just want to do some shameful advertising of an event that we have coming up. So one of the things we really wanted to do, because we've had students in our audience, we wanted to try to engage students in the seminar series by having the graduate students or undergraduate students actually present at one of the seminars. So that's going to be our March session. And Margot Parks came up with the format, which is a Betkus, which I've never actually been part of myself, but it's a 20-slide, 20-minute presentation.
Not 20 minutes.
What did I say? Sorry, 20 slides, about 7 minminutes, is it? Yeah, 20 seconds each slide. Sorry, I said 20 minutes. She's like, no, not that. So 20 slides, 20 seconds a slide, I think it worked out to about 7 minutes. And so to start this off, or to help encourage students to be part of this, we're offering a training session on February 21st. So we've already had at least 9 people sign up for that training session, which is wonderful news. No pressure. If you come to the training session, you don't have to decide to be part of the March seminar series, but it might also inspire you or give you confidence that, no, I can do this. I just recently was part of a 1-slide, 1-minute session. It's the first time I've ever had to do that, and it was super fun. I'm a talker, so I thought, well, I can't do this, but I did, and it was really fun, and it reminded me afterwards that I talk too much, and 1 minute is actually all I ever need. So please come. Margaret Parks, myself, Chelsea is here, Chelsea Peltier, Rachel Wells, we'll all be there. We'll have some pizza, we'll have fun, I'm sure, and I'm sure all of us will learn. And then if you decide following that training session that you'd like to sign up, we're going to have about 6 slots for the March session.
And if I'm not going to be here right at the end of this, but if you've got any questions, you can ask Shannon, who's the contact person as well, if you want to just ask us at the end of this session.
Yeah, and a big thank you to Shannon and Damon for recruiting, for organizing the event, and also for putting out their feelers and making sure that we have some people attend. So that's wonderful. Okay, so without further ado, I'm just going to introduce our speaker for today, Dr. Shannon Freeman from the School of Nursing here at UNBC. And I'm going to hand over to her. She has come up with a great format for us. We didn't know at the time that we were going to do a panel, but she invited a panel to be part of her seminar today, and she'd like to introduce those panel members to you. So I'm just going to hand over to her. Thank you.
All right, thank you so much. It's a really exciting opportunity to present to such a broad audience. There's lots of you that I recognize in the audience, and then there's lots of new faces too. So today, when I was asked to talk, I thought this is a really great opportunity not only to present some content and what we're doing, but also talk about process and opportunities and share some experiences from a range of people on our team. I think one thing about research is we rarely do research alone. We often work in teams, and everyone brings different strengths and enthusiasm and expertise to the team. So I'm going to talk about our work that looks at developing a suite of quality indicators for telehealth services in Northern BC, and we're going to talk about that program. So today I'm joined by Kevin Adams. So he's undergraduate health sciences student, some of you in the audience may know, who's been involved in this project right from the beginning. I think you were my first hire on this project. And next is Georgia Betkus, who's a master's student in interdisciplinary studies, who joined this project about 8 months ago. And Tim Wood, who's a master's student in nursing, who also joined about the same time as Georgia. And then there's my partner in crime at the end, Frank Flood, who's the regional manager of telehealth services from the Northern Health Authority. And we're very pleased he could come up the hill and join us today. And without partnership between Frank and I and Northern Health and UNBC, none of us would be here today. So a bit of our agenda and overview. We're going to talk about, what is telehealth really? Like, how do we understand what it is? And then what does telehealth mean to Northern Health? And what are some of the exciting things that are happening at Northern Health, and where are they now, and where are they going? Because this is one of the most exciting places to be in the country when we're talking about telehealth. Geographically, it's a perfect situation, but there are some of the leaders and innovators in new technology and finding technology solutions to real world issues to really improve the quality of life and quality of care of people in Northern British Columbia. And I'm very proud to work with Frank Flood on these initiatives. We're going to start with then we're going to move into a bit of our research activities. We're going to talk about some findings from our scope and review. So what does everybody else say about telehealth, and how can we use that information to inform what we are doing and where we are going? Then we're going to talk about our stakeholder consultation event that we held in Prince George last year to take all that information from the literature and really see, well, does it resonate with experts in the field? Then we're going to talk about our next steps. So we have all this information now, where are we going? And we're going to talk about some of the future directions for telehealth in Northern Health. And then each of our student panel members is going to talk more personally about their experiences and why they're here and what they're learning and what great opportunities they've had at UNBC in research. So first is our overview of telehealth. So where do we begin? Where does Frank and I begin this journey? I think it was mutual interest. So a bit about me, I'm a social gerontologist. I'm interested in all things about promoting the health and well-being of older adults, and especially when you add in rural communities, you have a lot of older adults who are isolated. And with geography and with climate, there's a lot of challenges, particular to this area, in accessing services. And so when Frank talks about all the exciting things about telehealth, I was like, yeah, I want to be part of that. Let's work together. Because I can see the opportunities for supporting telehealth to make real-world change. So we started out with a PHSA Northern Health UNBC seed grant, and that's what funded our scoping review and our stakeholder consultation activities, as well as some financial support from Northern Health to support the stakeholder activities. And then we have been successful this past fall to receive a bridge grant from UNBC to continue these activities further and looking at actually piloting these quality indicators in 2 services in Northern Health. So teletrauma, that's the project that Tim is championing, and telegeriatrics, and that's the program that Georgia is championing. So what is telehealth? I think it has a lot of different meanings depending on who you talk to, how they see it, how they imagine it, and different people call it different things. So if you actually go to search in PubMed, telehealth is not a subject heading, right? So we use the World Health Organization's definition that telehealth is the delivery of healthcare, or exchange of healthcare information using telecommunication technologies when participants are separated by distance. So that geographic component becomes really important here in the North. Telehealth is a lot more, though, than just video conferencing. I think a lot of people have that idea in their head when you think about telehealth. But this is a nice picture here to show you that telehealth can be between clinicians, so specialist to physician, physician to physician, interdisciplinary team members, That can be through email, through video conferencing, through a variety of hybrid of those. We have clinician to patient, where doctors are remotely connecting in to consult with patients. We also have patients to mobile health technology, and this is one of the really exciting, really developing areas. We talk about mobile e-health and all of the opportunities for the quantified self and life logging and tracking of your personal information, your personal health information. And there's great opportunities for telehealth to leverage that self-tracking information, then to connect it to clinicians to inform when follow-up is needed, when decisions need to be made, when contact needs to be made. There's a large number of different tools at all three of those areas, and there's a large number of services. So when we talk about telehealth, the whole concept of it is really huge. And what I thought was interesting is to say, in the States, over 60% of hospitals are connected using telehealth services. And indeed, in some regions now that they see where the connections through telehealth are actually exceeding face-to-face consultations in health regions. So we see a huge exponential growth in the use of telehealth between clinicians and between clinicians and patients.
Okay, this is me. All right. Everyone hear me? Okay, so as it says here, I've got some more emerging coursework, thesis work, and RA work. And so what this looked like for us was doing a concept analysis for one of my classes. And if you guys have done a concept analysis, I got to suss out what telehealth really means and what it entails. And also the giant mess that is telehealth, telemedicine, telecare, e-care, all that stuff. And so I really got the chance to focus on exactly what is telehealth and the concepts behind it, and delineate. This for me?
You can click your stuff.
Okay. And really find out how we can measure it and how we can look at telehealth. All right. So I used Walker and Avant's method for analysis, and it kind of led me to three main aspects of what telehealth, or what I thought telehealth was. And so the three up there, interconnectedness, and this was access to care. And the important piece here that I found was the temporal versus the spatial aspect. So of course it could increase the timely access to care, but it could also cover geographic dispersion. And I think there are some researchers at UNBC who also covered this and did a research project on this here. Another aspect that I found was optimization of care. And so this looked at things like cost savings, quality of care, diagnostic accuracy, and even access to expert advice. So the third one, technological integration, I think is pretty self-explanatory. Of course, it's going to have some technological component. But the interesting part of this is that, we've had this technology for a long time, since the 19th century, right? Telephone, telegraphy. Yeah. But telehealth it's not something so static that we either have or we don't have. It's more of a process of keeping up or evolving with technology and kind of using it to, improve care. If that makes sense. Yeah. Process, not so static, dynamic. All right.
Me. I concur. Telehealth is not just technology. It's what we deliver and why. Because we're looking at getting into patients' homes now, where we haven't before. We're reaching far on places. But what we need to do is connect people, is what we're doing. And so that's what the technology is going to do. So what we did about a year and a half ago is we had a 2-day seminar. From that seminar, we invited people from other health authorities, including First Nations Health. We invited from the ministry, other provinces, and from key stakeholders. And the idea is, the first day was, what do we do in telehealth now that's right, and what could be improved? And the second day is, where do we want to be, and what's important? So I might have jumped a slide on you, but I can still catch up. So what we found out is that for someone to use telehealth, right, it's got to be comfortable and it's got to meet their needs. It can't be a new tool or a new way of doing business. Otherwise, people just aren't going to use it. And the same with the patient. You've got to be comfortable using it. There's got to be a reason to use it. For the patients, what we're finding out is that traditional healthcare is expensive. They have to travel to it, which can be lots of wages. They have to come up with daycare. There could be travel and accommodation. There's food. There is also the fact of being alone unless you have someone to travel with. And where that's taken us is that when we deliver telehealth to a new community, we found 50% more people have the service that we're delivering, or have the need for the service we're delivering, than we knew was in there. Like for our renal clinic, we opened it up to a new community, and all of a sudden, patients are coming out of the woodwork because now it's accessible, and because they're going to use it more often. For our doctors, right, what we're also trying to do is we're trying to make sure that we give them other access, right, to continuing education, right, for different ways of getting reducing travel for them. Telehealth in itself, just being able to offer them the non-isolation of a physician that's been in a remote community and hasn't intubated somebody, and they have to, right? Now we have in the ER, we have the ability to connect another ER, somebody in the system, and help them with it, so they're not isolated. So a new doctor has access. Okay, this slide here, more. More communication, more primary care teams, more healthcare services, and yes, we want to do it. We have the tools and technology, and people are asking for it. So now we have to come up with a plan on how we're going to roll it out to make sure that we get it to the right people. And one thing to that is that if we take technology and I put it into a health center, and unless there is a demand for it, it won't be used. We found this time and time again that if we try to force technology or force a solution into an environment, it does not get accepted, and there's little uptake. So what we try to do is we try to make sure that when we approach a community, right, and we approach the community, not just the health center, that everybody wants telehealth and there's an excitement. We explain what can be done, we get everyone on board, and then we deliver the technology. And from that, we get great reception. Back to definitions, video conferencing, barriers, time, mobility, distance, weather. Weather is a factor for us. In a previous life, I was up in Nunavut for 10 years, and I implemented telehealth up in Nunavut, and weather was a huge factor. And now in BC, not BC, but in northern BC, especially with some of these remote communities, saving a medevac, right, is one, is the cost, that's a huge savings, but just getting the person to the care that they need sooner rather than having to transport. We have a service right now out of the Robson Valley, and what it allows is when a doctor is on call in the evening, he supports two communities. Before, what happened is that the patient would have to have an extra hour ambulance ride to travel from one community to the other to be seen. That's the first ambulance ride, then the second ambulance ride, and then the What we've done now is the doctor can connect from his home into either of the ERs, make a decision on travel, and right from there, bring in the Prince George ER, right, to help get a resolution sooner, right? So we're now connecting more places and more tools together so that the patient gets seen sooner. Okay, from that 2-day workshop we had, the biggest thing we found out was that there was misconceptions about telehealth. People thought it was expensive, took a long time to organize, and was difficult to use. And because of that, they weren't using it as much as they could. We had good usage, but we found out that we could have a lot better uptake. And so with that 2-day workshop, we created a 5-year plan. And in it, the biggest implementation was the idea of find out what people want, make it easier, make it more accessible, and give them what they need. So, go back to an old story. When I first got into IT, there was always a door, and people would go up to the door, the IT department, and say, I need something. And we'd open the door and say, okay, you need new accounting software. We close the door, and then we deliver the software to them. And we did the best job we could, but what we didn't do is we didn't really engage to find out what they really needed and what they really wanted. And that's what the 2-day workshop really outlined for us, was that we had to make the technology easier and more satisfying, and we had to have better access. And the second one was making sure that adaptation is taken up. And to do that, you have to write how to use it in a language that people need to be able to understand. So we'd have a lot more groups that we're involved with now that we get how to build the tools, how to write the documentation, and how to prepare access for them so that it's for them rather than us writing a technical document to give it to them. And now, with the 5-year plan, to develop it, what we've done is we've gone to all of the people like Division Family Practice, we've gone to the MAC, we've gone to the physicians' communities to find out what they want. And we've had great uptake from that. Now we actually have them coming to us, and there's a draw where they want to be involved with it. What they want to be involved in is, when they found out what we're doing with the ER in Robson Valley for the 2 communities, they're saying, well, shouldn't we have that in more communities? And so now they're looking at how do we get the physicians on board to want it, which is that first step. And then there is the dollars that has to come up with. So they're also helping with that and making sure that it all interconnects so that the doctors from one community have access to doctors from another community. And that's what I was saying earlier, where with the intubation, we've had that actual episode happen. Okay. Last one is on implementation. I think I've been covering this again and again. Is that when we try to go into a community, we go in there first with talking and making sure that it's wanted, that it's needed, and then we look to see what's the best way to implement it. That'll be the best reception, and from there we go in with the technology as the final step.
And so, building on that, I think that's exactly how our research partnership came together, was that from the university side, we listened. We listened to what Northern Health wants to do. We listened to where Northern Health wants to go and where are their needs. And so you heard Frank talk about the importance to make the existing technology better and to create an enabling environment to really support that, right? So then the question was, okay, so how do you know you're actually doing that? How can you measure that this telehealth service is actually having the benefits that you hope it has, the benefits that the community wants it to have, and that the whole, the goals and objectives of why you've implemented the services that you had. And Northern Health has a large number of different telehealth services. So you see my picture here of the fruit market. They're all fruit. All those services are telehealth services, but they all have their unique characteristics and qualities. They're all really great at different times for different purposes and not appropriate at other times for other purposes. And so when we talk together about really where is the opportunity for collaboration, where we can offer, we can contribute to the team and we can support Northern Health where they have the greatest needs, the idea was, okay, so how do we develop that measurement system, right? And we realized that there's no quality indicator system for telehealth anywhere in the world that looks at telehealth at the systems level. So there's nothing that looks at that fruit market and says, hey, that's a really high quality, great fruit market. We should all go buy our fruit from there, right? Instead, we have lots of different quality indicators that say, hey, we can measure the quality of that apple, and we can measure the quality of that orange, and maybe that pineapple, right? But how do we then compare the pineapple to the orange, the apple, when they're all different? And so that's really where the overarching purpose for our collaboration and all of these pieces of research are all fueling that forward so that we can actually develop a quality indicator system that's going to work at the systems level. So that's really where we came together. So we start by assembling our team with our different pieces of expertise. We do a lot of collaboration with the Centre for Online Health at the University of Queensland, Australia, with Dr. Melinda Martin-Kahn, who is one of the leading experts in the development of quality indicator steps in healthcare, right? And so we sat and we figured, okay, so how do we go and we determine what's known? What do we already know? Because we don't want to recreate the wheel. So how do we actually know that there isn't a system out there instead of that there isn't a system out there that we haven't found, right? So we decided on what's our best plan to answer that question first. We sought our funding support. There's great seed grant opportunities. And so when you have an idea, these are the first places that you go and look. You know, these small little pockets of money, I think hopefully will make the case by the end of it is you can do great things with a little bit of resources and to start to build slowly. So with our seed grant, we had two purposes. One was to determine what is known, and so we conducted a scoping review, and we looked at what are all the documents that Frank has and that exist in Northern Health, and then we brought together our expert team. So you can see here on the side that one of those activities in isolation is not enough. A feeds B, feeds C, feeds C, right? And that was really important for us to look at this not as just one little research project. This is a research program. So we're working things together. We learn things at each different stage, but which help inform and refine where we are to go next. So our research activities. So the first thing is, what does the literature say? And I think it's so important to always make sure that your answer isn't already out there. Because if we already had an answer that we could easily implement, we'd be done, wouldn't we, Frank? Unfortunately, we found out that was not the case. So Kevin.
So this is where the undergraduate researcher really comes into his own. So yeah, as Shannon said, they got together an expert panel to kind of suss out and look for what kind of research question we're looking for. And from there, we're able to scan the existing literature and kind of figure out what's going on to make sure that we're not kind of, again, recreating the wheel. So Melinda, Shannon, and Frank got together and did that. And then they went on and did a bit more research, and there's a existing framework that was developed by Levac, Cohen, and O'Brien that outlines a 6-step process to conducting a scope and review. And so my meat and potatoes was step 1 through 4, as I'll take you guys through. So the first part, again, was identifying the research question. And that was done with Shannon and Melinda and Frank, and we had some pretty late nights trying to figure out exactly what we wanted to research and figure out. And then once we did that, we conducted a systematic not an actual systematic review, but a scoping review with our kind of key terms across all these different databases. And as you can kind of see, we had pretty good representation from all sorts of databases with all sorts of input from different kind of interdisciplinary sciences. Like PubMed and Cochrane have different kind of specialties in which they primarily published and everything else. And Econlit and Business Source Complete gave us the kind of more of a financial aspect with some of the studies that have been published on telehealth and all that kind of stuff. So we got a really good kind of robust kind of sampling of literature that we then explored to see what was happening in the literature. And Trina, the librarian assistant, was absolutely fantastic in helping us make sure that this happened. So we would be nowhere without her, I'm sure. And so this is our Prisma kind of schematic of what we collected. So as you can see up in the center there. Over here, you can see kind of how many articles that we collected from the respective databases, and that kind of gives you a flavor for what we were able to collect in our literature search. And then this takes us through, initially we had a tremendous amount of articles. We had over 4,000 articles that we had to screen at a fairly basic level to get an idea of whether they were going to meet or not meet our inclusion criteria. And so we we used a system called Distiller, which gave us a really nice kind of clear-cut, fast way of moving through all 4,000 of those articles that, as you can see here, we were able to plug in key terms and fish those out of the abstracts and the abstracts of the articles that we collected. And so we're able to have a very quick and concise way of sorting through literature and seeing whether it was answering the questions that we were asking. And so we're able to take it through two different steps of screening. And so, we had a lot of help. This is a process which requires more than one person because we need reliability in terms of being able to go through this process and see if we agree on whether this article should be included or not. And we took this through two different levels of screening, which was all done behind the scenes, where we had two people simultaneously go through all 4,000 plus of those articles. And you can see here kind of what we're asking, what got included and what got excluded. Once we did that, we charted all the data in a program called Navivo. And basically what we did is we went through all those articles again that made it through the level of screening, and were able to go through those articles again and kind of pick out the things that we wanted out of those articles that we felt kind of gave us the best representation of what the literature was saying, which was able to take us to the next level.
All right. So this is kind of where I came in after Kevin did all the hard work for me. So this is where I really got to sort through what Kevin did and look at those tables and everything that was extracted, and really decide what we were going to present and how we were going to present it. So if you can imagine that there are 31 different service types with telehealth that we looked at, and each one of those service types measure different outcomes, you can imagine how many different outcomes we had to look at. So literally like pages, hundreds of, I won't say hundreds.
Oh yeah, no.
It's a lot of work, and it's a lot of, I bought eyeglasses this semester, not for vision. So that just kind of goes to show sometimes it's a lot of work. I'm young, I shouldn't have glasses. So that might have been a little rude. I apologize. Anyway, so we looked at all these outcomes, and we really had to decide how we were going to group them. And from this expert panel that was, with Shannon, with Kevin, with Frank, and with all those different experts, we found that we could categorize these different outcomes into four overarching themes or domains. So I've listed them down there at the bottom, and you can see patient perspective, provider perspective, cost optimization, and population health. So that's just a way to look at all of those different outcomes and organize them in a way that is universal. So we can look at any specific service and then apply that framework and compare it across any different service types, if that makes sense. So also, as Shannon said, in going through all this literature and all these findings, there was no existing framework on how to measure telehealth across all these different services. But we came up with those four main outcomes, or not outcomes, domains. So having these overarching domains, as I just said, allows you to evaluate and measure telehealth across any service, whether it's teletrauma, whether it's telegeriatrics, like what George is doing, or telemental health or telenursing, really anything. So you can really start to develop a universal framework on how to measure telehealth. Or with Shannon's great analogy with the fruit, we can measure all the fruits. Yeah. Okay. And it's also based on evidence, because everything that we pulled was based on relevant clinical outcomes. So there's evidence-based, as well as it also identifies gaps for future research. So doing this, doing the scoping review and getting these findings, coming up with the framework, it allows us to shows us where literature might be lacking. Also, Thomas research. And also, with those 4 domains, you can see where the concept analysis that I did for one of my classes kind of overlapped, right, with the optimization of care, the need for telehealth services to be easy to use by clinicians, like Frank mentioned, as well as patient-provider acceptance of the technology. So it was nice to see that my work kind of paid off, or coursework is useful. Right? Okay, next one. So these aren't...
My glasses aren't good enough.
There you go. Okay, so these aren't the in vivo notes, but this is just an example of some of the data extraction that we pulled. This is one little page, and I think it's about a half of a page, and we had 10 like this that we had to go through. So this is pulling absolutely everything we could out of those articles, and it was a lot of work, a lot of squinting.
We had about 106 articles that we had to transfer.
That's right.
Directly into Excel spreads that was informed by Novivo, and that was it's quite the process, and it was some massive Excel sheets that it took a long time.
That you can never print without killing quite a few trees.
No, it would probably take at least a whole tree to print out all the data that we had to collect from all these articles.
Yes, so this was a lot of Kevin and I sitting down late nights, eyeglasses, both of us actually. You have glasses too.
I'm on my way.
There you go. So it was a lot of work. But yeah, this is just an example of one of the tables there. And let's go to the next one. Sorry, data extraction. This is something that we came up with, just an example of some information that we could pull from the data. So we took those 106 articles that we came out with and put it to a graph for years of publication. So you can see that, research has been done on telehealth for the last 20 years. Like, research has been around, but it's just more recently being increasingly researched. I think it says 2012 there. There's just massive spikes in the research that's being conducted. And of course, it's going to decrease for 2016, 2017, just haven't been published yet. So there's a bit of a lag time, but there's a huge amount of research being published on this now. And, that comes down to stuff like affordability. In the 1990s, a video conferencing system will cost $100,000. And since 2000, I think it's dropped to 20 grand or less than 20 grand. And that's still almost 2 decades ago that there was that price drop. So it's just hugely more affordable and feasible now. So it's nice to see that lots of research is being done on it. And of course, the rapid development of technology that we're trying to keep up with. Okay, so these are just the top 5 services that we identified of the 31. Yep. So you can see down there that mental health is one of the most prevalent services that we identified that is being measured and having research conducted on, and followed by telestroke, telesurgery, etc. But I think Frank here can speak more to the mental health aspect.
Well, I can give some examples. Yeah, the mental health is it's such a broad umbrella for reporting on cardiac. So it's more succinct. I was when I was talking about mental health, I was saying we just are doing one now in Prince Rupert, where we have 3 psychiatrists that are on call, but they're not in the hospital. And so if somebody presents and they need to be put in the state room, how do you get them evaluated? You don't want to take them out of the room, and you don't want to wheel a big cart into the room. So what we do is we have a link as in you, let's say a web browser link, they click on. So the doctor that's with the patient phones the psychiatrist on call, psychiatrist clicks the link, and they're now in a video conference on the iPad that the doctor has with them. So the whole accounting takes place on the iPad, and patient seen that much faster. And this way here, it doesn't limit you to where the person is and the time. We just get healthcare there.
And this is just one of the examples of why it's always useful to work with a knowledge expert when you're conducting research, because we can look at these and say, hey, do those make sense to you? And that's an excellent opportunity, example of where we look at our findings and then we ask, you know, does this reflect what you know in your daily work?
Okay, still me. Making sense of the data. All right, so this goes back to what Kevin mentioned about really developing the research question and deciding on what exactly we want to know, what we want to figure out, because it guides the whole process of, you know, how we display data, how I'm going to make sense of it, or what I'm going to look at, or what we're even going to try to pull. So, yeah, of course, this is a collaborative effort. It was Frank, Shannon, Kevin. It was all before me. Kind of nice, but also not nice, because I have to go back and write post-it notes to myself, reminding myself of what the purpose of the project is. So that is actually a very useful tool. And then going back to those tables and those data extraction sheets, you know, professors always told me, you know, marinate in the data. And I guess that's, they love the food examples, but really you have to sit there and don't write anything down. You can't be taking notes or whatever, but, you know, you just got to sit there and read through it and just kind of absorb it, and whatever comes to mind, but really marinate with the data. So I don't know if that was nice. Well, it was, okay, yeah. It was what it was. And that it really was just marinating with the data and spending time with it. You know, Kevin had all that time because he was so fortunate to pull all that data and go through it. But yeah, I really had to sit down with it and just, I don't know, absorb it passively. Okay, so that was the familiarization part. Synthesizing the data. So synthesizing and presenting the knowledge gain, that really, I really had to keep in mind exactly who this is going to be presented to, right? Because it depends, you know, writing a report or writing a paper, you have to keep in mind who's going to be reading it, right? Is whether it's Northern Health or it's the public or it's somebody else, you have to write it to them so it makes sense to them. And so that was, you know, that kind of guided exactly what I was going to show, or even those tables that we had. Right, but in this case, it was to Northern Health, but in some circumstances, or with another paper that we're writing, it's going to be just for a public use journal. So it depends on, I don't know, what we're writing for. Good.
All right, back to me. So, as we're kind of referring back to Levac, Cohen, and O'Brien, there's 6 steps. We're on step number 6. And so Shannon was fortunate enough to, or kind enough to kind of invite me to participate in this next step of our scoping review, which was after we've kind of gathered a flavor of what the data is saying, is and how we collated on that onto our Navivo programming, was to present that to our audience, and our audience specifically being Northern Health, because that's specifically why we're conducting this research, is to conduct quality indicators for Northern Health telehealth programs. And so in order to do that, our next step was to kind of have a stakeholder meeting with relevant stakeholders in the telehealth community. And so that included representatives from UNBC, UBC, the Northern Health Authority, BC Alliance on Telehealth Policy and Research, Provincial Health Services Authority, PHSA, BC Minister of Health, Fraser Health, Vancouver Island Health Authority. And we also had, of course, Melinda Martin from Queensland and another physician who's involved in telehealth research from San Francisco. So we had a very kind of broad and kind of expert panel to kind of go over what we presented. And so we presented them with what was originally a 3 separate documents that we presented, saying these are some of the things that we found, different kinds of indicators that we've found in the literature, how the different data collection types impacted the indicators, and then also the cost benefit and the financial implications of implementing telehealth services.
Not a picture of Kevin, by the way.
Yeah, no, that is not me. Anyway, so this was all led by Melinda Martin-Cand, who was kind enough to kind of coach everyone through the process and keep us all on task after we had kind of sat down and delivered what we had collected and let the expert panel kind of chew on it and figure out exactly what they interpreted and what they wanted at the end of the day. So the consultations, like we initially came with the triple aim, we broke it down to operational, financial, and patient domains, and Georgia will go on to describe that.
All right, so now that we've talked about the stakeholder meeting who was there, I'm going to talk about what happened and what are the outcomes. So Kevin mentioned that all the information we presented at this meeting came from the scoping review and was organized by 3 different documents. But those documents were based on the triple aim strategy that Northern Health uses. So what is the triple aim strategy? If you're not familiar with it, it was developed by the Institute of Healthcare Improvement, and it's a framework that helps authorities to optimize their performance. The overall goal is to improve the population health, improve patient experience, while also decreasing the per capita cost. So we present to stakeholders with a number of potential themes that we pulled from the literature, and they also supported each element of this triple aim. Then we collected notes, recordings, flip chart pictures, and then in addition to this, the participants also voted on the themes and domains that they thought could be potential for developing the quality indicator. So here's an example of what the voting cards looked like. It was based on a 9-point Likert scale. When we analyzed the point or the voting, anything above 6 was considered positive, 5 was considered neutral, and anything less than, 4 and less was considered negative. So after the voting took place, we went through and collated all the data, put it together. And so here's an example of the experience of care that stakeholders voted on. As you can see, we presented them with 4 themes, so they're in capitals here. Standing to point to them, thank you. And under each of those themes, there were smaller domains that they also voted on. So if you're looking through the diagram above, you can see that participants thought acceptability of telehealth services was a good theme, that access was also a good theme, adherence, also a good theme, and patient costs. However, you'll notice that convenience of telehealth service was voted negative, and so at this time we're not going to consider that for developing quality indicators. Additionally, the organizational information communications technology was voted negative, and then at the bottom there you can see that costs reduced due to different models of healthcare services was voted neutral, and that's because some people thought that there would be some cost increase and some cost decrease, and that necessarily increase was going to be bad. It was not necessarily going to be bad. And then just to really drive this home, I'm going to show you another example. And this one is population health. So this one had 5 themes. And interestingly, nothing was voted negative for this aim, but there were some neutral domains, including the program, coordination, and appointment system, and improved efficiency of adopting quality of care. So again, that's people considering that not necessarily positive, but not necessarily a negative at the same time. So what did we do with this information? So after we had the voting and notes all together, we removed the themes and domains that received neutral or negative scores. And then we returned the information gathered in the scoping review to get an idea of the quality indicators that other researchers used to measure similar themes or domains. And just to drive this point home a little bit further, quality indicators are measures that can be used to gauge performance or quality and are often displayed as a rate or percentage. So in the next slide, I'll show you some examples. So this is what patient or provider experience looked like after all the voting and notes and everything were analyzed. So themes, you can see those were all the positive ones. And then moving over to quality indicators, those are some examples from the scoping review that other researchers had used to measure. And then, so our final goal of this whole project is that we'll be able to compare the fruit. So we've included a section here for grade. So that'll be the comparison or the quality, how good they are compared to the others. And currently we're at the quality indicator stage. So now that we have all of our themes positive, we're going to go and talk to the stakeholders again and see if they can identify any quality indicators that they think are already being looked at, and if there's other data that needs to be collected to measure these. So finally, one of the last major findings from the stakeholder meeting was that the participants felt that the triple aim fell a little bit short of what needs to be considered when developing quality indicators. As I mentioned before, the triple aim includes population health, reduce healthcare costs, and patient experience. But since telehealth includes a lot of participation from health service providers, they felt that the provider experience is really missing from the triple aim. So we moved from the triple aim to this new quadruple aim, and that's what we'll be considering moving forward. All right, now I think we're back to Shannon.
Yeah, so that's where we are right now, and so where are we going? So we're using that information, and we're drafting our stakeholder consultation papers for publication. We've already disseminated our information back to Northern Health, and now we're sending it out to the wider audience. And then we're using this information, so while we are searching for a larger size grant to really develop our whole suite at the systems level, in the meantime, we have a smaller bridge grant where we can pilot that at the service level. So we're looking at independently developing a suite of quality indicators for 2 different telehealth services in Northern BC, and then we should be able to compare them and get similarities to form a basis for moving the larger project forward. And we continue to write lots of grants to lots of different funding agencies, hoping that something's going to come.
All right, so this is part of our next step. So you can see here that we've got each one of the 4 quadruple aims here, and we've got our positive themes, our potential quality indicators, and a little placeholder for the grade or comparison. So moving forward with this work, we're going to continue to refine these quality indicators until we have the appropriate suite that can measure the telehealth service. And then I think Tim has
Oh, yeah.
as well.
Okay, so what Georgia was just going over there is a mock-up report card for our respective field services, right? So that was more specific to telegeriatrics and exactly how we're going to measure that within the quadruple aim, right? And this is my mock-up of how we measure it for teletrauma. So you can see those boxes on the left, that represents the quadruple aim. And then within those are specific indicators for trauma or for teletrauma that can be measured. So that just, this represents a way that we can, within each service, we can measure it in a universal way. right, that encompasses those four overarching domains. So these are just, hypothetical, right? This is our conception of them.
Just to put this into context, where did this idea come from? It's a couple of years old now. I was down at a conference, American Telehealth Association conference, and I was asked, so how's telehealth doing? Right? And I said, well, it's doing really well. And then I realized that I didn't know, right? Because all the feedback I'd gotten was patient survey, where we get a 95% approval rating every time. People are glad to be there, people are glad to see, they're always glad, and we want to keep it that way, but it's not really a reflection of how telehealth is doing. And then you go to a specific service like telerenal or renal and say, okay, how is your telehealth doing? But they're not measuring telehealth, they're measuring their renal service, with delivery by telehealth being one of the factors. So I realized we really didn't know, and I talked to my other courts and other health authorities and stuff, and we really didn't have any mechanism for saying telehealth is doing good, bad, or indifferent. And by the same token, we could never then say, if we make a change, did it improve or make things worse, better, or different? And that's where the idea came from. And then I went and I applied for the seed grant, and then I approached Shannon, and I was explaining the idea, and she was getting excited about it because it is a way of capturing a snapshot of the service. But part of the thing is wrong. If we're going to measure telehealth, we have to be able to do it in a way that is more universal. We can't have 500 different indicators for all the different flavors of telehealth. And so this project was to create these domains in a way that we could apply to any form of telehealth in a generic way. So the quality indicators feeding up the domains may be different, but the actual grade that you get on the domain should be consistent. And then all of a sudden you could say, okay, well, let's put Canada through or BC through this same domain and see where it plays. And we can see that Canada got an A, but Northern Health got a C. We can look underneath at those quality indicators then and say, that's what they're doing different, right? So that's where we want to be able to go to in the real world, is have a tool that we could use to evaluate telehealth in a way that it was not subjective, but empirical, to say if we make changes, or if we decide to deliver telehealth to this community that doesn't have it, what can we see as changes as an impact? And of course, by keeping the quadruple aim, we're trying to cover every aspect of it so that finance people are happy, so that we know that we're not increasing costs overly, or we're not increasing care at the same time, so that we can show a balanced report card, and then that would be the improvement telehealth. Hope that helps. Okay. Oh, I better go on slide. I went off script. Okay.
So next steps for telehealth for Northern Health, right?
Oh, okay, next step. We've got the primary care homes that are going to be a big factor. We want to make sure that we're ready for it. So as we develop tools and procedures and all these different things, we're trying to make sure that we engage them directly as they're being created. We're looking at the communities I mentioned earlier. We're actually talking community level, the health service administrator level, the physician level at the community, to make sure that what we can offer them and what they need matches up. And also, the expression of hanging fruit. We go in there and we go to a community and say, okay, this is what we're going to offer. And they say, oh, we're excited about this. Well, let's take advantage of it, keep that momentum going. Because you'll also find that within physicians, they talk to each other. And so if they're having a good experience, the next physician is going to want to have the same experience. So that's why we want to keep the momentum going. First Nations Health Authority, they've done a fantastic job of both putting their communities with telehealth in there. Now, all of a sudden, we have this opportunity to start delivering service to them right in their community. And, that's exactly, less travel, care goes at home, everything that we're supposed to be doing. Platform. You're probably not that interested in technology because it's going to change in a minute, but one of the things that we're noticing is that to use what we have at hand and then make it better. And so right now, you've probably heard of Link or Skype for Business. it's a great tool, right? And if we can use that and leverage that and put it so that a Skype for Business endpoint can talk to a video conferencing endpoint, wow, we've just put onto almost every laptop or computer around a telehealth endpoint. So what we're trying to do is we're trying to make sure that tools that people are already comfortable with, we can now integrate into what we already have that works. Betkus, not that you'll ever want to look it up, but it's just a new integration technology. It has a whole bunch of interesting features. One is called WebRTC, another acronym. And what it does is it allows for any properly developed browser, whether it be Internet Explorer or Firefox or whatever else, will have WebRTC built into it. And that means when you want to be able to use video conferencing, if you're using it via WebRTC, there's no more adding plugins, there's no more dealing with technology. It's now more seamless. Again, I've already covered this slide. It is about actually making sure that the experience is made better, that people understand and have access to it, and that it's a lot less cost. On the bottom part, clinical leadership, collaboration, and governance, that's a main part of the 5-year plan. Right now, telehealth, which is currently under the IT department, we now have a governance body that is clinically led. So as we look to expand telehealth, make changes, or decisions, we now have more direct clinical leadership to make sure that we're meeting their needs and not just a geek like me going out and finding the best technology. A lot of fun to play with. Pre-implementation, again, it's the standard stuff. We're trying to make sure that we're ready, that we have processes in place before we deliver it. So getting the staffing ready, making sure that we have the right people doing the right job. We're looking at now having a direct clinical engagement lead with telehealth, and that's somebody that can bridge the language between IT and clinical. So that when we go into a community, it's not going in there telling them about how good WebRTC is. It's about what this can do for you. And then one of the last things is that besides this report card, telehealth has to be able to be evaluated and reported on, so that everybody knows what's happening and decisions can be made at the higher level and filtered down. So we're reporting now right to the exec within Northern Health to make sure that there's visibility. And by that way there, we also have the ability to make sure if we come up with a great solution in the Robson Valley, that everyone knows about it so that we have everyone at the table that can make the decisions to put this into other communities. I think that's it for me.
Oh.
Two more. Connecting remote areas. One of the big things we have a problem with is in remote areas is bandwidth. You've always had that at home when you want to watch Netflix. As an interesting story, we have 3 communities on the coast that want to connect in telehealth. And so we did some experiments with them, telescoped the T1 line in, and we connected up them, and we got a connection. We said, wow, we've got another community online. Later on that day, we did another test and failed. Next morning at work, all afternoon failed. And we found out Netflix, right? The line in the community, as soon as it was there, in the daytime, the community was using the line. And so there wasn't enough bandwidth left to operate the telehealth. So we're competing with, with communities in general, just in how technology can be delivered to them. And one more. Okay, and again, this goes back to saying about technology. Betkus, we're expanding now. 2 years from now, Betkus probably won't exist and we'll have another technology. But the idea is to make sure that we stay current with what is there so that we can offer the best service. And the IT should have it in the background so it's super easy to use, right? And in the front ground, all they know is that it works and it's available. Thank you.
Okay, so now I think we're going to switch gears a little bit, and we're going to give more of the personal stories of the 3 students involved in research activities.
Yeah, so I see a lot of familiar faces in the audience. I know a lot of you were shanghaied here by Sarah Hiko in her class. But it really is, sorry, went away on my screen. Anyways, yeah. So this has been a fantastic opportunity. Last year, I was in a class and I heard about this opportunity through a former instructor of mine that Shannon was looking for research assistants to participate in this telehealth study. And given I have a bit of background as a regional stakeholder with Canadian Blood Services, I have I have some experience with looking at health care organizations from a systems level.
We lost our slide, so.
Okay. Anyways, it didn't really.
Oh, they're great slides now, though. You're missing the best one.
Yeah, that's the fun one.
Kevin's cat.
I'll continue on for you guys. Keep it short. Anyways, and then this whole research opportunity has been a tremendous experience. I was able to be mentored by some wonderful individuals, Shannon and Belinda being 2 very special ones, as well as a number of others, and then also being able to take some of the skills that I've learned and transfer them on to other individuals as the project went on, as people came and left. And this, initially I had no idea that I wanted to go on and do a master's, but I'm likely going to be going on and pursuing a master's here at UNBC with Shannon. She kind of shanghaied me and has convinced me it's a fairly good idea. And I think if you guys have an opportunity to look into it and get involved with research, I would 100% recommend it. And also get to know your ophthalmologist, because you will go blind.
All right. Well, I think this is a pretty good example of when technology works well, it's great, and when it doesn't, it sucks. So we have some great slides for you that you may or may not be able to see eventually. But I was going to talk about how I got involved with this project and what my role is now. So I joined this project just after the stakeholder meeting. I had done some other research work with Shannon, and she told me about this project that she was working on with telehealth. And I was interested with telehealth. I grew up interested in telehealth. I grew up in a rural community, so I can definitely see the benefits that telehealth can bring to rural communities. And I think it's important that we can measure these services so we know that rural populations are getting the same quality care as urban populations. So as I talked about before, my job was to look at all the data from the stakeholder meeting, put it all together. And then moving forward, I'll be working on the development of quality indicators and that suite to measure the success or the quality of telegeriatrics in particular. Oh, great. There's my grad picture, 2014. I'm in there. I actually graduated from UNBC in health science, and I wanted to talk a little bit about why I chose to come back and do interdisciplinary studies. I really like the idea of interdisciplinary studies because it's really student focused. You get to incorporate a couple different of your different passions that you may have. Mine is healthcare, but I was also really interested in geography. Again, coming from a rural community, so I felt that interdisciplinary studies really allowed me to study and kind of develop a program that was best suited for me. And then I've always just really liked research. I have a passion for lifelong learning, so I knew eventually I would come back to do grad school. And again, Shannon told me about this project, and I thought, well, great fit for me. So that's why I'm here.
Okay, so yes, rose-colored glasses came off. after undergrad, it's not all puppies and rainbows like it is in university. And for those of you who have joined the workforce and then gone back to school or just joined the workforce, you know, life kind of sucks. So I would eventually come up and vent to Shannon about my problems in the hospital, and specifically the disconnect between management or upper level management and the actual workforce for nurses who are working in the hospital, and all the changes that get implemented. And I think Frank can attest to some of that disconnect sometimes between managers and maybe. There you go.
Right, manager.
Yeah. So I'm kind of bad passengers here. Anyway, so I come and vent to Shannon every now and then she heavily encouraged, is that the right term?
Fired.
Okay, I'll say hijack life plan and put me into the master's program, and I thought it was a good way to make some positive change in where I work, and yeah, so that's what I ended up doing. Hence grad school. I just ended up realizing that I was complaining about there it is, complaining. Makes me sound like a terrible person, but I was just complaining about the way things were. But I'm a big proponent of personal responsibility, and that if you can do something, you should do something about it. So, and that really goes around in the hospital too. A lot of people to talk and to complain about the way things are, but nobody does things about it. So I thought this is the way that I could contribute some kind of change and do something. My passion is healthcare, obviously. I did my undergrad in nursing. I work in the hospital still, and do research for healthcare. So it's what I like to do. And I just thought, a lot of the times people in the hospital represents some of the most vulnerable at the lowest point in their lives, right? So there's a real opportunity to make some real changes and have some effect. So that's why I like it. That's why I'm here. Yeah, that's it.
All right. Thank you, Tim. And I think that's a really good piece to close on, is that, there's lots of exciting opportunities and things you can do through research to learn more yourself while doing lots of things that you may not have pictured yourself doing a few years before. So it's important, I started at the beginning, it says, we work in teams. We're a panel because not just one of us did any of these pieces of research alone. We always are working together, and we're able to do great things because we work in teams. So it's important that we recognize that we have a lot of really important partners on this project. So Northern Health is definitely a co-lead with UNBC in this work. But we also have very good collaborations that we built through that SEED grant with PHSA, with the University of Queensland Centre for Online Health. And also, we didn't mention it very much in this presentation, but we also have a very good relationship with the City of San Francisco and their telehealth leaders in the U.S. So when we eventually get funding for our large-scale work, we are a 3-country team. And so we'll leave it at that and open for any questions that maybe you may have for any of our panelists here. And we thank you for your time and for welcoming us today.
Thank you so much to all of thank you so much to all of you on the panel today. So I think we have time for some questions. Maybe people who are asking questions, if you just generally want the answer, then the panel can decide who will answer a specific question for one of the particular panel members. Maybe you can just state that before your question. So do we have any questions to start with? If not, we will see. Sure. Yeah, go ahead. All right.
Could you see?
Yeah.
I'm Jason Shannon. I couldn't see the particular quality indicators around patient experience, but I do work with colleagues who use telehealth. And one of the things they tell me, and if you look at healthcare, modern health, a lot of the criteria you're looking at are urgent care or renal care or trauma care. most healthcare interactions are not there. 90% to do with primary care and more chronic multiple disease. The relationship between the provider and the patient is absolutely critical in this. So I'll give you 2 examples. There was a telehealth project up in the Northeast which failed because it was a private company providing services to the community. All by telehealth, it didn't go. And we've got some very successful ones in the North where we have Indigenous community looked after by physicians who travel there once a week. Once a month, go for a week. And so what I can't see in your QI stuff, and right now we tend to be in a situation where we measure things and we compare things. We're missing out human experience and human relationships. So is there a way that in your quality indicators you would be able to bring something like that in? In my view, telehealth is not the solution. It's one of the tools for the solution. And if the relationships are not there, to me it becomes actually a problem. So I'd be interested. I don't mind your answers.
Okay, so great question, and that was definitely, first of all, I should also mention that Dave was one of the people who came to our expert stakeholder consultation panel last year. We are very grateful to have you there. I think it's important that we look at, there's a difference between quality indicators for telehealth and then quality indicators for quality of care for the service, right? And so there's a bit of a difference there. Capturing patient experience is really important. And the way to seek more feedback that we're going to go about in our process is when we get out there and look at the 2 different services, we have a whole other piece of consulting with patients about what they perceive are the important things that they would like measured and to capture that from more from the bottom up rather than the top down looking at it, which is I think what you're kind of getting to there. Frank, you want to add?
Telehealth is a tool, absolutely. And the idea here is how to improve the tool, right? Not that to make the tool replace any other kind of service delivery. The patient physician experience is the one that's needed the most. And the doctor goes into the community for once a week, and then he can use telehealth for the other 3 weeks to do the follow-ups that happen when he's not there. And so it continues the care level. For the evaluation piece, one of the factors on the triple aim and the quadruple aim is to do with the patient. And so we are going to try to make sure that however telehealth is moving along, we know that whatever changes and how we're reporting will reflect that. And then decisions are made. So if the quality of patient experience goes down by the patient reporting it, then we know that we've done something wrong.
Thanks. I actually, as someone who's not in this area at all, with a similar question that I had though, I've been involved in teleeducation through the medical program, and I always feel flat on the VC, and I struggle to get that engagement with students. And when we built when Dave built the medical program, we had a lot of face-to-face visits with colleagues. So I would say that in addition to patient experience, I wonder if also practitioner experience would also be included in that building relationship, not only with patients but colleagues, because it feels like, for me anyway, in my very limited experience with teleconference, not in the context of health but education, is those sessions are much more successful once you've made that personal connection and then you're delivering something. So anyway, a little bit of an aside, but similar thoughts I had while I'm hearing her. Any other questions we have from the audience? Our students, maybe how they felt to be involved in a project or how they got engaged. No, maybe we have actually online, right? How are we? Rachel, do I need to look here? Sorry, we can check No, you think I get better at this after team. Maybe I'll let Rachel do that. Maybe I could just comment, and maybe this will spur some questions from our students in the audience. I just wanted to thank you, Shannon, for bringing your students today, because I think all faculty in the room, reminded me anyway, that for me, my students in my lab are everything to the research program. They're doing the work. And what I hope you as students have seen today here is that when you come into a learning experience in a research group, you're not just doing something that you're told, right? That you maybe, which happens a little bit more in your undergraduate courses where you come into, in my world, a lab and you follow protocol and you get the results that have already been done. You're really integrated as part of the research team. And here we've demonstrated that we have leadership with Dr. Freeman and her partner here from Northern Health, but the students also have brought a huge amount of intellectual contribution to the group in addition to learning about research approach and things like that. So I just really want to thank you for bringing that to this session today, because I know it's extremely important for all of us as faculty, but I hope you as students also got to see that there, that it really, you really become a team member when you get engaged in research. And if you can find time, whether it's in your undergrad or whether you choose to do it as graduate studies, I would encourage you to do it because it really shapes the week. Yeah. Any other questions? Yeah. No, we're going over.
So I know this was about testing quality indicators, but I was just wondering, in terms of your patient experience, have you looked at participant readiness across the North? Because I know there were some earlier projects that have come as well, so how that kind of factors into that experience piece.
As far as the indicators, this is just a way of measurement tool that we want to put in place so that we can evaluate telehealth and make it better. But for telehealth itself, yes, we have a number of ways that we continually try to improve by engaging. For instance, even earlier on today, we were doing an exercise where we had one of the telehealth people go and sit through a clinic for half the day and then report back, right, on all the little things that happened. Not just, did it die okay, but it was, what was involved in the room. It turned out that one of the rooms was too big, where the patient felt a little uncomfortable to have an intimate experience in a room that had 8 chairs in it. It just didn't. The other one was where the physician wasn't large enough in the screen to make it look like they were in the room. It was more like they were small, and again, it distracts because they're not there to worry about that experience. They're there to get what they need to talk about. So we do that on an ongoing basis where we evaluate remote locations where you're out the experience on an intimate level. Does that answer your question?
Okay, I think we could go on and on, but we actually need to end the session for today because people have to get to other places. So I just would like to ask that everyone just give one more round of applause for our panelists today. We'll thank